بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, now we will discuss the issue of bone tumors, which will be handled on two separate talks. The first one will deal with the technical examination and the way of interpretation of different imaging modalities, including X-ray, CT, and MRI. Then the second part will deal with the remaining topics in this issue. As you all know that there are a lot of bone tumors, either benign or malignant, and we have a lot of imaging modalities, including the plain X-ray, conventional tomography, ultrasound, CT, MRI, and some of the angiographic techniques which are now performed through the CT or MRI. And also we have the value of bone scan, isotopic bone scan. Actually, we should know that the plain X-rays are very important in the evaluation of bone tumors, since they can predict the nature of the lesion in about 70 to 80% of the cases. And there are some recommendations that the brain X-ray should never be omitted in the investigation of bone tumors. And the X-rays should include a frontal view, lateral view, maybe oblique views, as in cases for the spine, for example. And also we may have a chest X-ray for the same case, looking for some of the effects of the tumor intrathoracic, as I will explain. Then what do you want to know about the bone tumor? There are some specific issues we want to verify, and we will show the value of each imaging modality concerning this topic. Let us start first by the site. The site of the bone tumor is usually one of the predictive factors helping in suggesting the possibility of the histologic type of the tumor. And you know, we have three anatomic sites: the epiphysis, the metaphysis, and the diaphysis. Then the plain X-ray is good for evaluation of the site of the tumor, and here you can see an epiphyseal lesion which is located in the epiphysis of the tibia, and this is a chondroblastoma, as I will mention, and this is a metaphyseal lesion in the distal part of the femur, representing an osteosarcoma, and this is the diaphyseal lesion involving the midshaft of the tibia, representing an adamantinoma of the tibia. Then the nature of the lesion, whether it is expanding or destructive or permeative. And what's important for us is to separate the expanding from the destructive lesions, since you know that most of the benign lesions are, or let us say most of the expanding lesions are on the benign side, while most of the destructive lesions are on the malignant side. And this is the difference between an expanding lesion. You can see the expansion of the proximal part of the femur, and representing a simple bone cyst in this case, and this is an example of a destructive lesion in the proximal part of the humerus associated with pathological fracture, representing an osteosarcoma in the proximal humerus. Then the margin can also be evaluated by X-ray, and we would like to know whether the margin is well demarcated and sclerotic, and this may suggest a benign lesion, or whether it is ill-defined and destructive, and this may favor a malignant pathology. And this is an example of a well-defined sclerotic margin in a fibrous cortical bone defect in the proximal tibia, and this is an example of a destructive ill-defined margin of a fibrosarcoma in the distal part of the femur. Then the matrix of the lesion, whether it is cystic or it may or may not contain calcium. Cystic lesions are usually interpreted as benign, and the calcium is one of the helpful diagnostic criteria to predict the nature of the lesion, especially those of chondromatous origin. And here you see a cystic lesion in the proximal part of the femur representing a simple bone cyst, and this is a calcified lesion in the distal part of the femur representing an enchondrome. Then the periosteal reaction is also one of the helpful criteria for separating the benign from malignant lesions. And you know that X-rays play an important role in the identification of the periosteal reaction. And this type of periosteal reaction is what's known as onion peel or lamellated periosteal reaction, which is suggestive of a Ewing sarcoma in the diaphysis of the femur. And this is what we call the sun ray speculation, which is a perpendicular periosteal reaction to the shaft of the distal part of the femur, diagnostic of an osteosarcoma. And this what we call the candle wax periosteal reaction, which is suggestive of a periosteal reaction secondary to inflammation, and this is the case of osteomyelitis of the femur, and this is the classic appearance of the periosteal reaction in cases of infection. Then you know that after the major advances in the CT scan and the MRI, the use of conventional tomography has been regressed markedly in the diagnostic battery. And in the era before these advancements in the CT and MRI, we used to have conventional tomogram for areas, especially those in the spine, and sometimes in cases of, such as in this example, a case of osteoid osteoma in the cortex of the tibia. And you know that this osteoid osteoma is usually associated with extensive periosteal reaction, which may mask the original lesion. And at that time, we used to use the conventional tomogram to show the original pathology within the extensive periosteal reaction. Ultrasound is one of the major tools in musculoskeletal imaging, and it plays a good role in evaluation of bone tumors. Being a real-time examination, this is very advantageous. It can easily differentiate the cystic from the solid masses, especially those extending outside the bone. It also can predict the nature of the fat, the hemorrhage, and the calcium within the matrix of the tumor, and you can use the Doppler facility to show the vascularity of the lesion and to guide the imaging needle biopsies to the reasonable site for taking a good biopsy and to avoid vessels and necrotic areas. CT scan is now one of the major tools in the evaluation of bone tumors. It has the ability to show the extraosseous lesion and to show the relation of this lesion to the neurovascular bundle, which is a very important issue. Also, the recent versions of the CT scans can perform this quality of 2D and 3D imaging, and it plays an important role in the detection of the craniocaudal extension of the lesion, to show the cortical destruction and to show the matrix calcification. Then CT is helpful in evaluation of some of the lesions which cannot be accurately seen on the plain X-rays. And if you look to this example, and you have a lesion in the distal part of the femur, it is clearly identified by the CT scan showing a well-defined sclerotic margin denoting its benign nature. Also, CT scan can predict or can show the perosteal reaction earlier than the X-rays, and it can characterize the extraosseous soft tissue component, whether it contains calcium or not, contains fat or not, and contains hemorrhage or not. Then bone scan, as you all know, is sensitive but not specific. It can show the site of the pathology but cannot predict the nature of the pathology in many situations. If you look to this spine, and you cannot easily appreciate the site of the lesion. Then by bone scan you can see that there is significant isotopic, the significant isotope uptake in the pedicle, and this was an osteoma in the pedicle of the vertebra. And in this example, you see numerous spots of increased tracer uptake throughout the skeleton, suggestive of metastatic deposits. An MRI has the advantage of showing the bone marrow changes, and this is a unique advantage for MRI, especially in cases where the plain X-ray looks almost normal, as I will show to you. And we have, as you all know, a lot of machines, MRI machines, which can be used in this particular domain, including the open magnet and the closed magnet, the extremity magnet as well, and the dynamic magnet. Actually, there are some recommendations whenever you are going to evaluate a bone tumor by MRI. And these recommendations include, number one, if you are going to assess a bone tumor around the knee, which is the most common location of bone tumors all over the body, then you should have the surface coil for the knee to evaluate the tumor at its anatomic site. But before this, you should screen the whole part of the whole part of the side, looking for escape lesions, for example. And it's recommended also to look on the opposite side to facilitate comparing both femora to each other. Then you should have both sides together, and you should examine the side as a whole. Then you focus on the tumor. And this is one of the major advantages of MRI, is the evaluation of the bone marrow. If you look to this plain X-ray, and you can appreciate that it looks almost normal, but if you look carefully, and you can see this sclerosis in the proximal part of the tibia, and you can also appreciate the loss of demarcation between the cortex and the medulla. Look here, you can see the medulla and you can see the cortex, but here you cannot differentiate between both. Look to the MR image of the same case, and you can see that there is a huge bone marrow infiltrating tumor involving most of the proximal part of the tibial shaft, as you can see. And you may also feel that there is some extraosseous soft tissue component. In this is the case of Ewing sarcoma in the proximal part of the tibia. Then MRI is also an important tool for evaluation of soft tissue invasion adjacent to the affected bone. It can also show the neurovascular bundle, and it has a very good role in evaluation of spinal tumors. You know that we have this facility which is known as the whole body MRI, where you can scan the whole body in two positions, the frontal one and the lateral position. And also you can have the facility of MR angiogram throughout the whole body. And this is preferred by many of the investigators, comparing this whole body MRI to the bone scan. They said that bone scan only can show the bone lesions, but the whole body MRI can also show the spinal cord. It can have an idea about the brain and some ideas about the liver, if there is focal lesions in the liver, and it can also show the muscles. It can show the femoral shaft as well as most of the bones, and also you can have an idea about the vascularity of the lesion. Then, how to know the bulk sequence? I have explained this many times in the lectures concerning the joints, but you know that the bone marrow is bright in the T1 weighted image because of the fat, and it is less bright in the T2 weighted image, and it may be less bright in the T2 star or gradient image, and the bone marrow will be very dark in the stir image. And you should remember that the stir images are very important in evaluation of bone tumors together with the the T1 weighted images because of the sensitivity of the MRI to the bone marrow. Then you know that fluids will have low signal in the T1, high signal in the T2, like this ganglion cyst, for example. And fat is the opposite of fluid. Fat will show bright signal in the T1 and less bright signal in the T2. Then the approach for bone tumors will be different from that approach provided by many of the books, and I think that this approach will facilitate too many obstacles that can face anyone is looking to evaluate the bone tumors in an easy way. I have divided the bone tumors into three major parts. The first part includes lesions with characteristic imaging features. So if you can see the lesion, you say that this is the tumor so and so. And let us say that this group is a spot diagnosis. Whenever you see the tumor, there is almost no differential diagnosis. Then a group of lesions which have a suggestive imaging feature, and they may need further evaluation by other imaging modalities or by even by guided biopsies. And this will include some lesions which may have some differential diagnosis in some times. And the last group includes lesions with no specific imaging features. You cannot predict the tumor, the nature of the, you cannot predict the histopathology of the tumor from the imaging, but you only say that, you can only say that this is a benign lesion or this is a malignant lesion based on the criteria I have mentioned. But the actual type of the tumor you cannot reach from the imaging, and you need the help of biopsy to reach the diagnosis. Starting by the first group, which includes many bone tumors, and this group with characteristic imaging features will include the bone island, osteoma, osteoid osteoma, osteoblastoma, enchondroma, chondroblastoma, osteochondroma, non-ossifying fibroma, fibrous cortical bone defect, giant cell tumor, and vertebral hemangioma. Starting by the bone island, which is not actually included within the bone tumors, but many of the books include this bone island within the benign lesions of benign bone tumors. A bone island is a sclerotic lesion, or it is also known as inostosis, a sclerotic lesion which affects any part of the skeleton, and commonly is seen in the spine as well as in the flat bones. It is absolutely asymptomatic lesion. If you perform a bone scan, you can see some faint uptake by bone scan, and the lesion may vary from very small 2 millimeter to about 1 centimeter, and it may reach in some cases about 2 centimeters. One of the most important features of a bone island is the speculated margin. And if you look to the bone island, you will see that the margin is serrated, which is the opposite of the margin of sclerotic bone deposit. The bone deposit, sclerotic bone deposit, will have a smooth outline, but the bone island will have a speculated margin. And this is one of the major differentiating points between metastasis, bone metastasis, and the bone island. You know, the bone island will be black in all MR images because of the sclerosis. And bone island may increase and may decrease in size on follow-up. And if it increases in size, this will make some difficulties in differentiating the bone island from sclerotic bone metastasis. Then if you want to differentiate between both, you should remember that the metastatic deposits have smooth margin. Metastases are usually multiple. Also, bone island may be multiple, but it's rare. This and in the bone scan, metastasis, of course, will show a strong tracer uptake compared to the faint uptake of the bone island in the isotopic scan. The second lesion is the ivory osteoma, or the osteoma which is solid. There is no cancellous bone inside this osteoma. This osteoma is very common in the flat bones in the skull, in the paranasal sinuses. You see here an osteoma in the frontal sinus, and this is also an osteoma in the floor of the anterior cranial fossa. This osteoma is solid. There is no cancellous bone inside. There is no medullary cavity inside. This osteoma is, of course, a spot diagnosis whenever you see a lesion like this, and it only represents an osteoma. The third one is the osteoid osteoma, and this is a tumor which is made of osteoid non-calcified bone, and this lesion is represents about 10% of all benign bone tumors, and it usually affects boys in this age group. The common sites include the femur and tibia and the spine, as well also the spine. 80% of the tumor will arise inside or close to the cortex of the bone. And whenever this lesion is in the cortex, it will initiate an extensive periosteal reaction, and this periosteal reaction may mask the tumor itself, which is formed of radiolucent non-calcified bone. Then this lesion is metabolically active, and whenever you do a bone scan, you see a very strong uptake by bone scan. This is an osteoid osteoma in the tibia, and you cannot see the tumor because of the extensive periosteal reaction masking the tumor itself. But the axial CT scan of the same case, and you can see the nidus, or what we call the tumor, which is made of osteoid non-calcified bone. Sometimes you see internal matrix calcification inside the tumor, and sometimes you cannot see this, but you can appreciate the extensive periosteal reaction around the tumor. And this is a classic appearance of osteoid osteoma in the iliac bone, showing a sclerotic margin, radiolucent osteoid matrix, and calcium, which is usually located in the center of this tumor. Then you came to the next one, which is the osteoblastoma. And the osteoblastoma is, let's say, a large osteoid osteoma. The osteoid osteoma, the size ranges from 1 to 1.5 centimeter in diameter, but the osteoblastoma is larger than this. And 90% of the tumor occurs in this the second and third decades, and a major part of the lesion may affect the spine, especially the neural elements, including the pedicle, the lamina, and so on. And this is an example of an osteoblastoma affecting the pedicle on the left side. There is an expanding lesion, and there is matrix calcification, which may not be in the central part of the tumor, and in the bone window you appreciate the extensive sclerotic reaction which is surrounding the tumor. Actually, the tumor, if it arises outside the spine, you cannot predict its nature. You will say that this is a benign tumor. But if it arises inside the spine, it can be easily spotted as osteoblastoma. Then this will show increased uptake in the bone scan. CT is good in the evaluation. MRI may have some difficulties in appreciating the matrix calcification and the bone sclerosis, but CT is more sensitive. When you compare osteoblastoma by osteoblastoma, then osteoblastoma is larger in size. It's an expanding lesion. It may have a soft tissue component, like you can see here, and it will show multifocal calcification, which is distributed haphazardly through the tumor. The next one is enchondroma, and this is a common benign tumor of the skeleton. It represents about 12% of the benign tumors, and this is the age incidence. Then this lesion is very commonly seen in the short bones of the hands and feet, and it is an expanding. You should remember that any chondromatous tissue within the tumor will show calcium in the plain X-ray and also in the CT scan. You know that calcium detection by MRI is bad, but we will appreciate this by CT and even by the plain X-ray. And this is an expanding lesion which may contain calcium. You frequently seen in the bones of the hand and feet. Then the presence of matrix calcification is one of the characteristic signs of any chondromatous tumor. Then very frequently this tumor may be associated with pathological fracture. Multiple enchondromas can be also seen in many cases. As you can see in this finger, there is an expanding lesion here, and there is another one in the proximal phalanx, and you can appreciate the pathological fracture as well. MRI can show the expansion of the lesion here, but it cannot appreciate the presence of calcium. And then this T1 weighted image, you see the low signal matrix of the tumor, and the T2 weighted images, you can see the high signal matrix of the tumor being and expanding. The cortex is more or less well preserved. Then you think of an enchondroma of the finger. Enchondroma of the long bones, like the femur of the tibia, will not be an expanding lesion. It only shows matrix calcification, which can be appreciated by CT and also by plain X-rays. But if you have the MRI, the tumor will be black in the T1 and bright in the T2. It will show a sclerotic margin, which will be black in both T1 and T2. And also there are multiple black foci within the tumor in T1 and T2, representing the calcific foci. And this I have explained this in the lecture of the knee, that this may be an incidental finding while examining the knee for other issues like meniscal pathology or ligamentous tear, but you may mention this and say that this is an incidental enchondroma. Then whenever the enchondromas are too many, you call this all-year disease. And here you can see that the hand is almost involved totally by multiple enchondromas, and also the distal part of the radius and ulna, and maybe the carpal bones, and this is known as all-year disease. And sometimes all-year disease is associated with multiple hemangiomas of the soft tissues of the hand or the feet for example, and the hemangiomas are diagnosed by the presence of these calcific foci. These calcific foci represent philippuli, and the detection of philippuli within the soft tissues is diagnostic in many cases of soft tissue hemangiomas. The association of hemangiomas and enchondromas in the bones of the hand is represents the diagnosis of Maffucci syndrome. Then multiple enchondromas is diagnostic of all ear disease, and whenever you see philippuli, you consider Maffucci syndrome. The next tumor is the chondroblastoma, and then chondroblastoma is classically an epiphyseal pathology. This lesion is present in the epiphysis before the epiphyseal closure, and then this is an expanding lesion, osteolytic lesion. Because of the chondro, it will contain some foci of matrix calcification. Then you see an epiphyseal lesion here in the epiphysis of the femur, and you should remember that if the tumor is enlarged or became larger, it may extend into the adjacent metaphysis. Then how to judge if this is an epiphyseal lesion that has extended into the epiphysis, or if it is an epiphyseal lesion that has been extended into the metaphysis? Look for the major part of the tumor. As we say, always look to the bulk of the lesion. If the bulk of the lesion is in the epiphysis, then this is the origin of the lesion. If the bulk of the lesion is in the metaphysis, then this is the site of the origin of the lesion. And here is the bulk of the lesion is in the epiphysis. This is a chondroblastoma. And this is a classic appearance of chondroblastoma, show in physical pathology, showing a sclerotic margin, and you can appreciate the matrix calcification. And whenever these lesions are examined by MRI, you may have some difficulties in appreciating the nature of the lesion, but remember, in epiphyseal pathology is suggestive of chondroblastoma. By MRI, you will not appreciate the matrix calcification, but you may appreciate the sclerotic margin of the tumor. And this is the T2 weighted image, and you know that these tumors are associated by evident bone marrow edema, which will show bright signal in the T2 weighted images. And this is an example. This is a chondroblastoma in the epiphysis of the tibia, and this you can by MRI appreciate the sclerotic margin of the lesion, and you can also see some extension of the tumor into the adjacent metaphysis across the physical line. And if you look carefully, you can see the extensive bone marrow edema showing bright signal surrounding this tumor. The next one is osteochondroma, and this osteochondroma is let us say osteoma with a cancellous or a medullary cavity. This medullary cavity will be continuous with the medullary cavity of the original bone. The cortex of the original bone will also be continuous with the cortex of the lesion. This lesion is also known cartilage cap exostosis. It has a cartilage cap on its distal part. Then we have two types of this lesion: the pedunculated one, which may have a pedicle, and the sessile one, which does not have a pedicle. This is an example of a pedunculated one, and this is a sessile osteochondroma. Osteochondroma is an osteo and the chondro represents the cap of the cartilage covering the distal part of the lesion. You should know that the medullary cavity of the lesion is continuous with the medullary cavity of the original bone, and the cortex is also continuous with the cortex. The lesion usually grow away from the joint line, and the MRI here is very good for detection of the cap of the cartilage, since you know that the cartilage is containing water, and water will appear of low signal in the T1 and high signal in the T2 weighted images. This is a typical example of an osteochondroma or cartilage cap exostosis in the distal part of the femur, showing the typical radiographic features. And this is MRI proton density image and T2 or stair weighted images showing an osteochondroma, and here you can easily appreciate the cap of the cartilage. The cartilage contains water, and water will be of intermediate signal in the proton density and high signal in the T2 and stair weighted images. Then this is an osteochondroma. And also this is the sessile osteochondroma in the distal part of the femur, and in the T2 weighted image you can appreciate the cartilage cap, which is of bright signal containing water. And you know that this cartilage cap should not exceed 1 centimeter in thickness. Otherwise, you may predict or suspect that this tumor is turning malignant. If the cap is thicker more than 1 centimeter, then you may think that this tumor is turning malignant. And you look here, this is an osteochondroma by the plain X-ray, by CT, and by MRI. And you can easily appreciate that the cap is very thick, and also the underlying bone is eroded and irregular. Then these are the two main criteria suspecting the malignant transformation of an already existing benign osteochondroma. Whenever osteochondromas are multiple and extensive, as you can see here in the distal part of the femur and the proximal part of the tibia and the humerus, and it may affect many parts of it, and then you are dealing with what's known as multiple hereditary exostosis or diaphyseal achalasia. And diaphyseal achalasia is a hereditary bone disease, which is an autosomal dominant disorder, and is diagnosed easily by the presence of extensive multiple osteochondromas all over the skeleton, as you can see here in the knee and in the humerus as well. The next two lesions are extremely intimate to each other, which are the non-ossifying fibroma and the fibrous cortical bone defect. These lesions are benign lesions, and they are most commonly asymptomatic, may be multiple, and may heal spontaneously. From its name, its fibrous cortical bone defect means that the lesion should be in the cortex of the bone and is made of fibrous tissue. Then it will appear radiolucent, and the margin of the lesion will be sclerotic, as you can see here. This fibrous cortical bone defect may heal by getting ossification or calcification of the fibrous tissue inside the lesion, or may progress to a benign tumor which is known as non-ossifying fibroma. Then there is no sharp margin between the two pathologies. Then frequently in the books and on the internet you can see this diagnosis: fibrous cortical bone defect dash non-ossifying fibroma. This lesion may represent a fibrous cortical bone defect or may represent a non-ossifying fibroma. Here you can see multiple small lesions in the cortex of the distal part of the femur representing fibrous cortical bone defects. And if you look to the lesion in the frontal X-ray, you will see that the lesion is in the cortex, but in the lateral view you may feel that the lesion is located inside the medulla, which will lead to a false interpretation. Then you should interpret the bone tumors using the two standard views by the X-rays. And it is advisable not to diagnose these lesions by MRI, and you may do some mistakes because MRI is not sensitive for the fibrous tissue, and fibrous tissue, as you know that MRI will show fibrous tissue of low signal in all pulse sequences, but many times In this fibrous cortical bone defect or non-ossifying fibroma, it will show low signal in the T1 and high signal in the stair, as we can see here. And it's easy to appreciate this lesion by the plain X-ray and by the reconstructed CT images rather than to diagnose these lesions by MRI. And if you see a lesion which is cortical but it is sclerotic and is not radiolucent, then you know that this fibrous cortical bone defect has been healed and it is now filled by bone or by calcium. Then fibrous cortical bone defect may heal, and this is a healing one or healed one, and may progress to a non-ossifying fibroma. The next tumor in this group is the giant cell tumor or the osteoclastoma, and this is a locally malignant tumor. This is not a benign lesion. It appears after the epiphyseal closure, after the age of 20 years. And here you cannot see the line of the physis. Then this tumor will arise after epiphyseal closure. However, there are some exceptions for this, ranging around 3%, which may appear before the epiphyseal closure. This lesion is commonly found around the knee, and it has an eccentric location. It usually affects one side of the bone, whether it is the tibia, the fibula, or the femur, and it has no sclerotic margin. It has no sclerotic margin, and for the diagnosis, this lesion should reach the articular surface. The tumor should reach the articular surface of the affected bone. Like this here, you see an expanding lesion reaching the articular surface of the tibia. There is no evident sclerotic margin. And sometimes you got pathological fracture, of course, and being a locally malignant tumor may show malignant changes in about 1/5 of the cases. And this is a classic appearance of giant cell tumor in the distal part of the radius. There is an expanding lesion reaching the articular surface of the bone. And this is by plain X-ray, and this is by reformatted CT images showing a giant cell tumor in the distal part of the ulna reaching the articular surface, and you can see the expanding nature of the lesion. Then this lesion must abut the articular surface. It must have a margin which is non-sclerotic, and this lesion is eccentric, and you remember that a good percentage of the tumor may have recurrence or malignant features. Then giant cell tumors are usually benign or locally malignant, let us say, and few will have a evident malignant criteria. Usually by imaging you cannot differentiate between the benign type and the malignant type of this tumor, and you see an expanding lesion in the distal part of the radius reaching the articular surface, and it has no sclerotic margin. You cannot say if this is the benign virtue of the tumor or the malignant one. Then the common sites for the giant cell tumor include the distal part of the radius and the femur, as well as the proximal part of the tibia. Then this is an MRI of giant cell tumor in a female 13 years old before epiphyseal closure, and then this is one of the exceptions, as I have said. You see an expanding lesion, and this lesion is reaching the articular surface. It will show low signal in the T1 and high signal in the T2, and this was a giant cell tumor. The last one in this group is the vertebral hemangioma, and I will discuss this in details after that, but you should know for the time being that vertebral hemangioma is an incidental finding after the development of MRI. Usually you can see the hemangioma as a bright focus within the vertebra in the T1 weighted image and also in the T2 weighted images. But Many times you can see vertebral hemangioma of low signal in the T1 and high signal in the T2, and this will make some difficulties in differentiating hemangioma from, let us say, metastatic deposits in the spine. I will explain this in full details whenever I am discussing the issue of bone metastasis, and also I will discuss this in the issue of the spinal tumors, inshallah. Thank you very much. Alhamdulillah Rabbil Alamin.